Welcome, my friends, to the Bob and Brad podcast. My name is Mike, and I am filling in today for Bob. Unfortunately, he came down with a cold, and his voice isn't quite up to par yet. So I am filling in for today's podcast with Dr. Abbasi. Dr. Abbasi is a two-time guest. This will be his third time. He is a board-certified neurological surgeon, and Dr. Abbasi is one of the nation's leading spine surgeons. He specializes in minimal invasive spine surgeries. On today's podcast, we'll be discussing how COVID can affect your back pain, as well as various types of spine surgeries. So without further ado, please welcome Dr. Abbasi. All right, we're going to switch topics now to discuss one of your spinal procedures called OLLIF. Do you just say it like that, or do you call it OLLIF?
We call it OLLIF, but OLLIF is the official title of that. The abbreviation stands for Oblique, Lateral Posterior, Lumbar Interbody Fusion, or OLLIF. There is another procedure. It's called OLLIF, Oblique Lateral Interbody Fusion dash ATP, anterior to psoas, and that surgery is done through the belly. Our OLLIF, we don't have to open up the belly. We go all from between the border between the belly and the back, and these are just anatomical description about how we get access to the lumbar spine.
Right. And if people are more interested in that part, we did a podcast with you previously where you really discussed the differences on those. But for this portion, we're going to kind of compare the OLLIF type of surgery to the traditional type of back surgery. So
absolutely,
I guess the first question is, how does OLLIF vary with the muscular cutting and reattachment compared to traditional back surgeries?
Yeah, that is actually the core of the difference. For obvious reasons, spine is in the middle of our body because it has to hold up straight up. And but that means to get to it from any direction, you have to go through a lot of adjacent tissue. And that is the bad part of the spine surgery as general. There is a saying in spine that we say spine surgery begets spine surgery. So meaning if you add one, you will need more. Part of that is that by the time we do the first surgery, it causes so much damage, we make a weak spine even weaker by literally, in an open old-fashioned surgery, detaching all the muscles. Do you play sport? Do you do any kind of sport?
Yeah, I mean, I used to play football. Yeah, I used to play football and I distance run now, but if you don't have functioning muscles,
imagine you play football. You're not going to have any football. Now imagine you go to your doctor, he does surgery on your knee. To get to the knee, he had to cut the tendon, but at the end of the surgery, he decides he's not going to reattach those tendons. Your knee will become physiologically not functional, so you can say goodbye to your football.
Yeah, I mean,
this is exactly what we do in the spine surgery. In the spine surgery, we cut the muscle, we cut the tendon, but we do not reattach them back. If any surgeon like me, and as a matter of fact, this is a secret of the spine surgeon that we don't tell our patient often, that in a regular spine surgery, we cut the tendons, we cut the muscle, but we do not reattach them back. If we ever have to go back, we see it, we know it, it turned into scar. They're not muscle anymore, they're scar. But for a long time, we didn't have any other option. So the options were letting the patient be in horrible pain or destroying all the physiology of the spine and turning it into scar. So reluctantly, we took the less of the evil by performing the surgery. And for that reason, we have been very restrictive to offer this kind of surgery to patients because we know all the side effects, all the other damages that it can cause. But having said that, by avoiding cutting the muscle, we have brought the spine surgery to a next level. And that's what OLLIF do. OLLIF does perform and achieve the good part of the result of the surgery without all the collateral damage, which is cutting the muscle.
Right. So how does recovery time and restrictions vary with the OLLIF type procedure?
And that is, I think that's been a crown the achievement of OLLIF. Like considering that many of these surgeries has been a 7-day hospital stay, and now we do them and patient go home same day, is because patient can walk so much faster. They can achieve being independent so much faster. I'm talking about the truck driver and farmers who are practically, if you would have told me in 20 years ago, 15 years ago, that something like that is possible, that the farmer within weeks after a spinal fusion goes back to work, I would have not believed that. But now, this is the crown achievement of the OLLIF, that by not causing too much collateral damage, patient walk within 1 to 2 hours. Usually after open surgery, it takes them a day or 2 or 3 to walk.
Right.
Patient go home. 96% of the patient go home within the first 24 hours of the surgery. After open surgery, less than 5% of the patient walk within the first 2 days, whereas our patient, 96% of them walk within the first day. After open surgery, about 4 to 7 days hospital stay. After our surgery, usually an average 1.6 days. And as well, return to work. Most of our patients, if they do desk job, after 2 to 4 weeks are back to go to their desk job. If they do physically demanding job, it's going to take longer. But in either way, open surgery need 3 to 4 times longer for the patient to achieve the same kind of benchmarks, be able to do the same activities.
Right. Yeah. I mean, this is just like light years ahead of what it used to be in recovery time. I mean, obviously people that haven't had back surgery don't realize it, but working in, therapy, if I worked with someone that had your surgery, it'd be a lot easier than the traditional style. So when we're comparing the two, true traditional and OLLIF, which has more of an increased risk of nerve damage?
Yeah. Now, any kind of surgery that you perform has risks involved in that, including nerve damage, risk of infection. Let's talk about all risk of any kind of surgery on the spine, with the most common one, infection. A regular surgery has 3 to 5% risk of infection. 3 to 5% meaning 1 in 20 almost. And if you have seen one of those infections, they can be deadly.
Yeah.
Our surgery has 0.2% risk of infection. As a matter of fact, not a single patient of ours has to be taken back to surgery for infection. In a regular surgery, we are very close to the tough membrane around the spinal cord. We call that dura. A regular surgery has about 8.7% risk of that practically the skin or the membrane get damaged, and then that is a part of much bigger problem, that there is a hole in the spinal cord or the area where the spinal cord is covered. Our surgery has 0 risk of that. Then other risk of obviously is bleeding that would require transfusion. In a regular surgery, depending on kind of the surgery, but in general, about 20 to 35% of the patient need blood transfusion. In our surgery, practically in all our regular surgery, not a single patient needed blood transfusion. Only one patient who had a liver disease, was coagulopathic, needed blood transfusion, but that's such a rare event. So we went from 20 to 30% to almost 0 need for blood transfusion, to a point that I just treated a Jehovah's Witness. Jehovah's Witness, as you may know, they often, because of their faith, they decide not to have blood transfusion. And for that reason, many of these patients, even with horrendous spine problem, are rejected by spine surgeon because they clearly know that without blood transfusion, the surgery cannot be done safely, because they lose a lot of blood in open old-fashioned surgery. We lose like half a cup or a quarter of a cup of coffee blood, which everybody can tolerate. So many of these Jehovah's Witnesses come to us because we can take care of them. With us, they don't have to decide between their faith and their health.
Right. I
So
mean, 'cause how big are like your incisions if you were just to hold your fingers up for the camera?
yeah, no, in an open surgery, the incision in the spine can be like my hand.
Hmm.
In my surgery, we do multiple incision, but each of them are the size of my fingernail.
Oh, yeah, they're tiny. So, yeah,
Yeah,
obviously
they're
that's going
tiny.
to lead to a lot less blood loss.
Absolutely, absolutely. And as well, under the skin, when we don't cut the muscle, we have less blood. Now, regarding the nerve root irritation and the nerve injury, I have a good picture and I can show it to you or I can send it to you. You can include it in this.
Right. I could put it over top if you want to send it to me.
Our spinal cord is like a tube coming from our brain down. At each level, there are two nerves on each side going out.
All right.
So in any regular surgery, we have to push on the spinal cord and the nerve root because that's the way to get in. As a matter of fact, the standard of treatment, what we call transforaminal lumbar interbody fusion or TLIF, the definition is you cut the bone and you go just between the spinal cord and the nerve root that comes out. In that corner, we call it axilla of a nerve root. We go in and so we put both spinal cord and the nerve root at danger. In our surgery, we don't even come close to the spinal cord. By the way, you remember we talked about the risk of nicking the spinal cord, which
Yep.
is with open surgery 8.7%. Ours is 0 because we are not even close to the spinal cord. But we have to push the regular nerve that comes out to the side. So whereas open surgery put them both at danger, our surgery has a risk of only irritating the nerve root. We looked at that systematically. In the study that we published, the risk of nerve irritation for open old-fashioned surgery was 12.7%. Our risk of nerve was about 8.5 or 8.6%, so 50% less. But it makes a huge difference because people with open surgery, the next day after the surgery, they're so miserable, they don't care that the leg is a little numb or more numb. If they don't have the pain, they're happy. Our patients are ready to go home. So they say, I feel great, but I have a little numbness here. What's that about? So it appears psychologically more, but once we looked at that systematically, scientifically, actually the risk of nerve root irritation is less with us. Now, in literature, the permanent risk of nerve damage after open surgery has been reported. There are lots of papers out there, but it's reported the highest 35% to the very, very lowest on a handful of cases, 0.3%. But the reality is, if you have 35% and if you have 0.3%, the reality is that it is somewhere between. 35% is maybe too high, 0.3% is maybe too low. The reality is that risk is probably around 10 to 12%. In our surgery, initially, we have as well about somewhere between 10% irritation. But then after a year in our study, only one patient in 303 has still meaningful symptom, meaning our risk of nerve damage is 0.3%, which is the lowest. So a very small fraction of the open surgery based on the data we have available now.
Right. I caught most of that. We were glitching a little again, but it should be good.
Okay.
So do you guys have your own type of protocol at Inspired Spine that you run through people? And does some of this protocol prevent you guys from actually needing to do surgery on people?
Absolutely. Our goal is to take care of the patient. And we have a saying we have few doctrine in the Inspired Spine. Our first doctrine is that we take care of everybody. Now, many spine surgeons and many spine services, when it becomes a difficult situation, they do the right thing for the practice and just don't deal with difficult situation. Our take on that is we take care of everybody and anybody. This is our first doctrine. So even if you have been part on medication or drug dependent, even if your situation is very hard, even if you are elderly, we take care of everybody. this is our first doctrine. Our second doctrine is that if we can help anybody without the surgery, we will not do surgery. What that means is that we have extensive protocols. When the patient comes to us, we run them through specialized protocols to see if there is any chance we can help them without the surgery. As a matter of fact, many of the patients, even now, as they run them through our protocols, they wouldn't even qualify for surgery in our service. We still let them do some other treatments. Some get better, some don't, but then we do the surgery. So we have extensive protocols to help anybody can be helped without the surgery and to try to avoid the surgery. We call that multidimensional. There is something that we track, and it can be tracked easily, is about how many patients you see in the office, how many surgeries you do. We call that clinic to OR ratio. That number generally is between 12 to 15%. Ours is 8%. We perform less than most of other services, spine surgery based on the patient we see now. Having said that, we are not delaying the care. If somebody needs surgery, we do the surgery. But if there is a chance that patient can be helped without the surgery, we take that first.
Right. And that's kind of uncommon for surgeons. I mean, most people think surgeons want to just give you surgery to fix your problems. So this is something newer, I would say.
No, and unfortunately, you're right. You know, I wish that we surgeon, but we are like hammer. We see everything as a nail, and that is our problem. But having said that, I have almost in every clinic, I have a patient who tells me, you know what, the other doctor looked at me 5 minutes, said, you need the surgery, and walked out, and you're telling me you want to try other things. Thank you for not just seeing me for 5 minutes and writing me up for surgery. Patients do appreciate that. Patients are smarter and better informed than ever. They have the tools to go and look you up, look at your result, listen to other patients. And that's what I tell our patient. There's so much information you can get on your surgeon. Get to know your surgeon.
Right. Yeah, it's more common nowadays just to look stuff up before you go through with surgeries.
Absolutely.
I guess my last question about the OLLIF surgery is how much time on average would you say the surgery actually takes with this compared to traditional back surgery?
And the answer to that, I want to use an analogy because that makes people understand that. Because when I say that I did the surgery in 40 minutes, same surgery that another surgeon needs 4 or 5 hours, they cannot wrap their head around it. They say, you must be cutting corners or you must be speeding it up. Nothing could be farther from the truth. Like imagine you drive from here, from where you are to Chicago. I would say that's probably 6-7 hour drive. Is that about right?
Yeah, probably roughly.
Yeah, roughly 6-7 hours. Now imagine if you don't know airplane exists, if driving is all you know, and somebody tells you he got from you to Chicago in 1 hour, you would think he's lying or he's a very bad driver. He's a reckless driver, correct?
Right.
But if you know the driving versus flying, it's normal to drive from your place to Chicago in 7 hours, but it's as well normal in your place to fly from your place to Chicago in 1 hour. It's all about all the time that you don't spend in cutting the muscle and stop the bleeding, literally cooking the tissue, makes the surgery so much faster. But all of that reflects as well in patient's outcome. Like in that all the 5-6 hours that regular surgery is being done, we literally are cutting the muscle, stopping the bleeding, cooking the tissue. Patient is laying on their chest. This data is undisputable. Every additional 30 minutes under anesthesia adds 17% to the combined risk of the surgery. So by us making a 5-6 hour surgery, a 1 hour surgery is tremendously less risky to the patient. And that's why we can do this surgery on elderly. Nobody else can.
All right. Well, I think that gets everything we have for questions here. Do you have any last comments or remarks you would like to add about anything?
No, thank you so much.
All right, and that concludes today's podcast. I hope everyone enjoyed it. I apologize. We had some lagging internet issues, so hopefully I am able to fix it up enough so it is tolerable to listen to. Make sure to come back next time for more interviews with experts on the Bob and Brad podcast.